chapter 2 of my career, recognizing that disc issues were caused by biologic issues, discovered when I was 15 years old, working in the Division of Neurosurgery at Penn State, led towards me trying different biologics. And the first biologic that I tried was something that was common, but I was wrong. I tried stem cells and I tried PRP. I didn't know why I was wrong, but I was wrong. And today I know why I was wrong. The reason stem cells have really no business being used to treat discs, nor do PRP have any business to treat discs, is because they leak. It's a leaky disc. There's no doubt about that now. It's that leaking disc caused by tears of the annulus fibrosis that allow that inner gel to leak, the nucleus pulposus gel to leak, and it's a biologic inflammation. So I needed something to treat that leak. The stem cells failed because they leaked themselves. Oh, and by the way, that was proved in many studies where stem cells were labeled. They had tracers put on them. They were radio-labeled and injected into discs. And in the very best case scenario, less than 15% of the stem cells remained in the disc. So stem cells are not appropriate for a disc, and neither are PRP for the same reason. And so then it hit me that fibrin was the perfect treatment for healing a disc, because fibrin was an FDA-approved drug, and it had strong bioadhesive properties. That's what we needed. It was a torn, leaky disc. And so I recognized that by injecting fibrin into the annulus fibrosis of the disc, that I could seal the disc, allowing that gel to stay inside. And that's how my research was refined. I initially was first diagnosing the problem in an old way using MRIs. We know what MRIs have no value in identifying the exact source of low back pain. I was then using discography to pressurize discs because that was the gold standard. That fails, and that's accepted now, that it wasn't sensitive enough, it was primitive. Discographies were primitive. So the test that made sense to identify a leaky disc was a test that targeted the disc tears, and I called it the annulogram. I called it the annulogram because it's a picture of the annulus fibrosis. And so it's straightforward. I inject the contrast into the annulus fibrosis, identify the tears. I see the contrast leaking around those 17 layers and out any tears onto the spinal nerve. And I love it when doctors visit, they all say the same thing. Wow, I didn't know what I didn't know. And then you'd be correct if you thought, okay, Kevin, you see those tears, Dr. Pauza, but you don't necessarily know which are causing the symptoms. I agree, I don't. So I do the logical thing. I treat every tear. So I introduce fibrin to every tear. The fibrin's a very efficient bioadhesive. It seals the tears. It becomes a part of the disc. Patients are transferred to recovery. They stay there for 30 minutes and then they go home. And then they go back to their activities the following week. And the Discseel procedure makes so much sense compared to any other regenerative medicine treatment that would leak from a disc. We know the disc is the problem. Even though facets and ligaments are involved, the problem's the disc. It's the disc, it's the disc, it's the disc. So fibrin makes sense. And that's why we don't want the Discseel procedure to be confused with any of those lesser regenerative medicine procedures that rely on stem cells or PRP.